We want to talk today about elevated liver function tests. My goal here today is to give you a lot of practical knowledge. There's a lot of esoterica, and we're going to actually talk about a little bit of hepatitis C this morning. I want to compress all of what you guys need to know about hepatitis C into about 10 minutes. Because even among gastroenterologists, and I go to many GI conferences, there are now algorithms, computer programs, just like we heard about before, to try to figure out which of the products to talk about and to use for our patients. So there's a lot of stuff that we're going to be talking about today, all of which will be practical information. The most important of which, because hepatitis C, what's happening to hepatitis C these days? It's going to be curable. We use the term SVR. Anybody familiar with a sustained virological response? That's our GI terminology, but basically from your perspective, many of them and most of them will be now cured. So that disease is going to be going away as long as the HMOs and our government decide to pay for the very expensive medicines. But the key of what we need to know about these days is this fatty liver disease. This is the epidemic. And we talked about a little bit about this the other day, but the objectives here today are to define non-alcoholic fatty liver disease, NAFLD, non-alcoholic steatohepatitis, to identify at-risk patients, review treatment options, review commonly encountered gallbladder and biliary tract issues, and again to review what we need to know about hepatitis C as primary care providers. So let's start with something fairly simple. And again, I'm going to start on the right side of the room, and I want on the left side of the room, and I want that right side of the room to start thinking about how they can keep up with the left side of the room. Ernie is a healthy 20-year-old gentleman, never had any medical problems. He broke his leg last week, and a surgeon is calling about the elevated indirect bilirubin of 2.6. What do you suggest as the next steps? Nothing. Congratulations. What are we dealing with? Gilbert's. Wonderful. The other side of the room agree? Okay, that's wonderful. Because it's surprising how many of the consults I'd gotten in years gone by, and patients were starting to fill out their wills already and just saying, well, I'm going to be seeing Dr. Buck, and this is going to be it. They don't even need to see gastroenterologists, right? There's no need. So you guys already have it, but let me show you some of the things that go along with Gilbert's. Autosomal dominant, incomplete penetrance, due to defective transport and conjugation of unconjugated bilirubin. And again, there's nothing that we need to be concerned about. So if you happen to be Artie, I'm coming to this side of the room, and let's see how we can do on this side of the room.
Peter?
Yes.
May I just point out something real quickly?
Yes, sir.
Okay. So I used to play racquetball with my boss, and whenever he would play racquetball, competitive, his eyes would turn a little yellow. And then after, hours after, it would sort of go away. And I also had a friend, when they would fast for the Jewish holidays, would also, or under stress, would also just turn a little yellow. Urine never turned yellow, and asymptomatic, totally asymptomatic. So those are just, there are some situations that can also bring this on.
Correct. Any sort of stress.
So
that can be part of that process. So right side of the room, I'm counting on you to help me go through this process. And what we want to do when we're going through this process is, first of all, stay away from the other end of the pool when Artie's going in. I think that's extremely important. There's going to be a tsunami there for sure. Artie is 5'8", 285 pounds, type 2 diabetes. You can see what the sugars are, see what the medicines are all about. And the exam is unremarkable except for, obviously, the obesity. There's the blood pressure and the glucose and the rest of the results. Let me point out to you ALT of 120. Let's see if this pointer doesn't work too well. ALT of 120, AST of 100, cholesterol 270, triglycerides 200, and the CBC normal. So we've got something cooking, and what I want to do is just kind of discuss how far a primary care physician wants to go in evaluating. This is some of the suggestions that I have to make it a little bit easier for the gastroenterologist, because my purpose in being here is to make that relationship with a gastroenterologist a lot easier. And sometimes we hardly need to use a gastroenterologist. We can just have a lot of information there before. They can do the procedures that they need and send the patients back to us. But here are the key things that obviously we need to look at as primary care physicians to get that alcohol history, medicines for potential hepatotoxicity, obviously illegal drug use, checking hepatitis B, hepatitis C, iron and non-binding capacity because we're looking for hemochromatosis and ferritin, of course, as well. And then I always get that question, you know, we get some of you guys are just so into it. You do anti-mitochondrial, anti-smooth muscle, anti-LKM, ceruloplasmin, and the rest of that. Is that necessary? Alpha-1 antitrypsin. Here's my man, alpha-1 antitrypsin. Yeah, so again, this is the basic information. If you guys happen to want to do the rest of that, okay. If not, leave it to the gastroenterologist. But this is the basic information that we really should have, because again, I remember in years gone by, and it slows up the process. It slows up the process of getting information back to you and getting back information to the patient. I have a patient just sent over with elevated liver function tests, and no basic workup has been done. You know, so this is part of it as well. And you know, there is a component of this where an ultrasound should be considered as well, depending upon the circumstances. So let's continue there. What is non-alcoholic fatty liver disease? We can see. Right side of the room, what are you seeing there? A lot of fat. There's clearly fat there. What else causes fat in the liver besides some of these unusual medications? What else causes it? The big thing that we're all worried about. Alcohol, right. So there is no difference between what we see here and what we see with alcohol. It's the same exact pathological appearance. Our job as primary care physicians is to make sure what kind of alcohol they're taking. Are they taking substantial amounts of alcohol or not? If they are not, if they're taking just minimal alcohol, by minimal I mean maybe one drink 2 or 3 times a week, then it's non-alcoholic fatty liver disease. And if they're taking substantial alcohol, then it is you know, alcohol-induced liver disease, and that's a somewhat different entity, but the same kind of outcome. But we've got to be aware of that, and I wanted to make sure that you guys know about it. So let's go to the next one. Does that change with abstinence? Let's go to the helpline on the other side of the room. The other side of the room, does this change with abstinence? There we go. They are right. So subjects with non-alcoholic fatty liver disease have a 10% higher mortality than without non-alcoholic fatty liver disease. Tell me why. Cardiovascular disease, that's exactly right. Sometimes I get the answers, so I've saved this one for you. There you go. Basketball season. So sometimes I get the answers, and I want to make sure you don't get the wrong answers here, of cirrhosis, hepatoma, and the rest of that. They're not going to live long enough to have cirrhosis or hepatoma. You've got to take care of their metabolic syndrome. If you don't take care of their metabolic syndrome, they're going to die long before they can potentially have cirrhosis and hepatoma. So that's the key. That's the important message that I want to share with all of you. So non-alcoholic steatohepatitis. So what I want to point out to you, since the pointer does not seem to be working very well, is there's a blue component on the right lower side. That is a fibrotic component. That's the scarring that we're talking about. And that's what happens. And it's the same process that happens with alcohol-induced liver disease as well. So it's the same thing. It's just that we know that these people are not drinking on a regular basis. So is NASH associated with any symptoms? You said no? Then you get the reward. Okay? No, you'll be rewarded. There you go. Catch. That's exactly right. Next one, the statistics. This really shows what you guys are up against. And occasionally, in years gone by, maybe when I presented this 4 or 5 years ago, my audience of primary care doctors was very resistant to this concept. This is a tsunami of difficulty that is headed your way. You need to be aware that there are going to be a lot of cirrhotic patients and a lot of hepatoma patients who do not fit the usual category. These are these patients. 100 million in the United States with potential for non-alcoholic fatty liver disease, and 25 million with potential for NASH. Now, I figured this out the other day. I challenged myself to figure out how many gastroenterologists there are and how many potential for NASH and non-alcoholic fatty liver disease. That would mean that if we were very aggressive in pursuing all of these, every gastroenterologist in this country would be performing about 25,000 liver biopsies to make sure. That's not going to be the case because we're going to show you how to help prevent this problem and show you how we can avoid the liver biopsies and even the potential for a GI consult and many of them. Here are the risk factors: evolution of man or de-evolution of man. The risk factors, all the things that you know about, and again, things that go along with metabolic syndrome, diabetes, BMI over 28, high adipose tissue, and age over 60, all part of this process. So why is it important for all of you guys to know about? It's important for all of you to know about because of the risks for cirrhosis, and NASH is becoming, it is not becoming, I didn't have a chance to change this, it is the #1 cause of hepatocellular cancer in the United States at this point. Because again, everybody said before that we're on the road to curing hepatitis C. And in the road to curing hepatitis C, we've made enough inroads that it is now the fatty liver disease that is going to become the #1 source for cancer in the United States. All right, let's go for it. Learning exercise. Okay, we're doing very well. So most people know it's around 10%. What's the 10-year risk of liver cancer in NASH? It's kind of a shocking figure. It's changing as we look, but I will tell you that it's 20%, so it's that high. So this is to kind of give us a reality check of what we're talking about and what we have to deal with and what we have to worry about. This is a trick question. Everybody got it right. Liver biopsy clearly is the best way to diagnose NASH, but is it the way that you're going to be getting it coming into your office? Think about it this way. My friend here already knows, and he's going to be amply rewarded because I got the light bulb here because I can see that you're shaking your head. So the light went off because it's not the liver biopsy kind of patient that's going to be coming to your office. You're going to get the patient who went to the emergency room Saturday night at 3 a.m. and had the right upper quadrant pain, probably had a gastritis or an indigestion. The ultrasound was negative for gallstones, right? You're already smiling. It was negative for gallstones, but it showed a fatty liver. Return to Dr. Grayson as soon as possible so that he can follow up and make sure of what he wants to do with that fatty liver. So that's how it's going to end up ending back in your hands. And liver biopsy, of course, is the best possible way. Why don't we like to do lots of liver biopsies in these people? Number one, there's not enough gastroenterologists to do it. What are the risks with liver biopsy? Bleeding, pain, okay? And if you go through the side of the area of the lung, pneumothorax, right? You can even get pleural reaction if you just don't penetrate the lung. And I'm not dissuading people from doing liver biopsies. Liver biopsies are pretty safe. But if you can avoid a liver biopsy, and that's part of the other message that I'm going to share with you today, if you can avoid a liver biopsy with non-invasive testing, isn't that a great thing? And we already have that with hepatitis C, and we're going to talk about that in a little bit. So not all of these people need liver biopsies. So the message here is clear. The message is most of these people are going to end up in your office because they came from a radiographic procedure where there is fatty liver. Uh-oh. So what are the standard ways of treating NASH in 2016? We went through this. We went through this a little bit yesterday. And exercise. How many people are successful in getting their patients to exercise and lose weight? Let me see those hands. Okay, tell me why. How do you get them to do what you want them to do?
Explain the future risk of hepatitis C.
And you scare the crap out of them. Right. I think that's a wonderful way, but we're not all successful with that. I would say only a certain percentage, unless you're exceptionally good about this, only a certain percentage of these people are going to be compliant. Correct? Yeah, only a certain percentage, and we just spend that time with them, and then hopefully they'll be successful. Now there are a few tricks that we've learned over time with regard to exercise. I'm going to give you a personal example. Having an exercise partner, that works for me. Some people like the apps, especially the younger physicians like to recommend apps to their patients. But whatever seems to work. So you have to know your patient. You have to get deep inside their skull to make sure that they are going to be compliant, and to do the exercise and weight loss, which is the bane of most of our existence in primary care, to have them be compliant with something as simple as this. Hepatitis A and B vaccination. So let me come over to the right side of the room and tell me why this is important. It is an additive effect. It's an additive effect. Now that goes for any liver disease. So if you have a pre-existing liver disease, it doesn't only have to be fatty liver. So I'm going to give you a little nugget. It can be hepatitis C, any liver disease. If you get another liver disease on top of that, it has an accelerated downhill process of deterioration, and that's why it's so very important. I can tell you from the gastroenterology perspective, and I want to re-emphasize that for you, my primary care colleagues, that gastroenterologists are not very good with regard to immunization. I have the statistics. I think about 30% of us are compliant with immunizations. So we need to double check. You need to double check our work to make sure that these people have been properly immunized. And clearly, to avoid alcohol is part of this process as well, and extremely important. Here is my important take-home message of today, and I'm coming to the other side so I can look you guys in the eye. I wanted to make sure that you realize that I am looking at you as well. So on this side of the room, the degree of weight loss and the resolution of non-alcoholic fatty liver disease, look at that figure on the right. If you lose more than 10%, look at the percentage of resolution. And that's why it's so important with regard to making those patients have those changes. Because if they can do something as simple as losing the weight, they turn around the non-alcoholic fatty liver disease. I'm not saying they turn around the NASH part, but I'm saying at the earlier phase, we can make a tremendous difference. Look at that. That's an incredible thing. And now we'll talk about the controversies over medicines to treat NASH. And there are there are some controversies, and we're going to talk about them. So vitamin E. Anybody give vitamin E for patients with non-alcoholic fatty liver disease? Okay. Oh, I see over here. Okay. So tell me your experience with regard to vitamin E and non-alcoholic fatty liver disease.
I'll see improvement, if not resolution, depending on the severity.
Okay. So I'm going to ask you a few other questions. So you see improvement, significant improvement. Do you have any difficulty in giving it to your male patients?
No.
No. Because?
Because I don't.
Okay. That's fine. Hold on to that thought, because you're going to learn something here. Is there any problem in giving vitamin E to male patients? Left side of the room. What's that? Close. Close. You're getting there. How about prostate cancer? There is a relationship, and I learned this from my audiences, so that's why I love working with you guys. And I'm not dissuading you from doing it. I just want you to have this information. There is an association with vitamin E and prostate cancer. And it has, in some of the most recent liver meetings this past year, not 2016, 2015, that was disputed. So the literature is starting to be disputed. But there is an association. And I wanted to go over a couple of other things that we can learn together. So in these patients who had NASH, 80 patients had gotten 800 units, international units for 4 years. The most important of which was the improvement in histology. So not only liver function tests improved, but the histology as well. So do I recommend vitamin E? And the answer is, for ladies, absolutely. For men, I might be a little bit more cautious about that. It will still work, and it's probably going to be safe, but I would add that prostate cancer information. And there's another alternative if you have a patient who's a little bit hesitant about that. So instead of giving 800 international units, 400 international units has been suggested by some authorities to just say it's less provocative for the potential for prostate cancer. So again, prostate cancer is out there. Is it a huge thing? No, I just wanted you to be aware. Actually, I wanted the entire audience to be aware of that as well. Here is my trick, and obviously this is not one of the liver biopsy needles, but this is how I get people to be compliant. Dr. Buck comes and faces the patient face to face. You don't want me to do this liver biopsy needle, and probably I get even a bigger one to show them. You don't want me to do this? And occasionally we get people who get themselves in line with what needs to be happening. But I'll tell you the most frustrating thing in dealing with these people, and I've dealt with hundreds over the years, is that I have this discussion, and I say, we're going to see you again in 3 months. In 3 months, they've gained 15 pounds. I can tell you that's among the most frustrating things that I've ever seen, even after this discussion. But the point here is not that I'm going to rush into a liver biopsy, but it kind of induces them to think about getting themselves taken care of. Okay, does weight loss surgery or gastric balloon insertion have a role in the treatment of non-alcoholic fatty liver disease? Clearly, the answers are yes, it will. Obviously, weight loss surgery is not a prime reason for taking care of non-alcoholic fatty liver disease. But I want to give you a highlight of what is happening because the fields of weight loss surgery, weight loss techniques, and fatty liver disease are kind of coming together. Who out there remembers Garin Edwards balloon? I need to see those hands. Garin Edwards balloon. Remember about 20 years ago, we had this wonderful technique of throwing balloons in the stomach to allow people to have early satiety and to lose weight. And so you're starting to shake your head. You're starting to remember that. And there were complications. People got obstructed, and they aspirated, and some died, and it was taken off the market. Well, lo and behold, there are new balloons out there. So those of you who are connected with large medical centers may find that instead of a Garant-Edwards balloon, which was a single oval balloon, there are now devices with 2 balloons inside there, which supposedly cause less problems. They are FDA pending. There is a device out there which is just beyond belief. Ready for this one? Which is basically like a gastrostomy tube, but allows people to eat and evacuate the material coming out. It's out there. It is FDA approved. I couldn't believe it when I'd seen it. It's out there. So this is amazing stuff that's going on out there. And obviously, I throw it to you for your entertainment purposes, but you may be seeing a patient who had this done by somebody else, and you say, what the hell is going on here? Right? It's right. Right. Ripley's, believe it or not, is right down the street, so it's going to be part of that in just a couple of years, you'll see. Susie. So we're done with the fatty liver part. We're moving on to something else, something very practical. Susie, 60-year-old female, otherwise healthy, severe right upper quadrant pain, past 2 weeks, nausea, vomiting, cholecystectomy 5 years ago. This is the typical kind of stuff that you guys are going to be seeing, and you guys refer to us gastroenterologists. Look at the rest of this. Cholecystectomy 5 years ago, no medicines, moderate right upper quadrant pain, CBC liver function test, stole cold normal, lipase normal, cholestatus post cholecystectomy on the ultrasound, normal common bile duct. What do you suggest? I already had an answer here, so I'm going to start with this side of the room, an MRCP. What are you looking for in an MRCP? Yeah, choledocholithiasis. What's the chances of a patient like this having choledocholithiasis? And I'm not dissuading you. My thing is to, my message here is to start thinking about what we're doing and what the consequences are going to be. So you ready to answer my question? The chances of an MRCP showing something, very low. Excellent. So you got my message. And I'm not dissuading you from doing that. Again, you know, every once in a while we can pick this up. But with this kind of picture, it's going to be very unlikely to have anything special going on. Occasionally, I get people who say other things. Anybody want to say repeat an ultrasound from this side of the room? Because I'm looking at you guys. No. Occasionally, I've repeated an ultrasound under these circumstances. And you see, suddenly you see stones. So it may be worthwhile. Anybody want to do an ERCP? Don't give me a heart attack this morning, please. Why don't we do an ERCP under these circumstances? What's that? The liver function tests are normal. And what are the risks? The risks are enormous. The risks are enormous. They are enormous in ladies who are young, who have normal common bile ducts. The chances of getting a post-ERCP pancreatitis are much higher than the general population, so never consider that. Occasionally when I do this, I have people say CAT scan, and I won't disagree with that because, again, every once in a while you can get a hypernephroma, you get something crazy going on that has absolutely nothing to do with the biliary tree. I wouldn't disagree with anything like that. And again, occasionally I get people who say, do an endoscopy. Maybe it's peptic ulcer disease. I wouldn't disagree with that as well. So you're thinking in the right way, and that's great.
Peter?
Yes, sir. We're going to go and answer this one first. So what will we do now based on the likelihood of what's happening?
Because I wanted to ask you something.
Hold on a second. We're doing Jeopardy. What will we do now? So I can turn off the music. So treat her. It's either treat her with an antispasmodic or for muscle pain or stress factors. Certainly not biliary manometry. That's a much more invasive thing. Let me get the music off and then I can answer the question. Yes, sir.
Okay, so on this case here, it turns out she never had stones.
Correct.
She had a biliary study that showed she had a sluggish gallbladder, and the surgeon took out her gallbladder. And she's no better.
Correct.
So my question is Is there such a thing as post-cholecystectomy syndrome?
There's absolutely post-cholecystectomy syndrome. And again, there's a myriad of ways of approaching that. Sometimes if you are still suspicious, so let's go back, I'm sorry, we're going to get back to the music, but, oh, maybe not. Perfect, we don't have the music. So with post-cholecystectomy syndrome, and we've all had those kinds of patients. They're borderline kind of people. They may have a little bit of irritable bowel syndrome. They've got some stress factors, but they got really significant right upper quadrant pain. Liver tests have been pretty normal. Ultrasound could be normal. They have a family history that always adds. My mom had it. They'll usually tell you, my mom had it. The doctors couldn't figure it out in Maine. I came down to Connecticut, and in Connecticut, they took out the gallbladder. She was sitting with pain for 15 years. The key here when you're having this post-cholecystectomy syndrome, which means you take out the gallbladder, there's still pain, you can look a little bit further. So you look at things like an endoscopy, you look at things like sometimes biliary manometry, and if anybody's particularly interested, I will tell you a little bit about that afterwards. I don't want to spend a lot of time with that, but that's another one of the sophisticated tests that can be done. And there are a whole bunch of other tests that can be done, but basically you are going to end up treating them symptomatically. You're looking for other things, but you're going to be treating them symptomatically. So let's move on from there. So Myra. Myra is going to be a little bit different, and we're going to approach this a little bit differently. Myra is 42 years old, and Myra had also a cholecystectomy, no meds, temperature, slight scleral icterus, moderate right upper quadrant tenderness, something different is going on. Ultrasound, status post-cholecystectomy, 1 centimeter common bile duct, which you can see is dilated. Would we approach this differently? Yes. And I'm going to ask other people. I appreciate your answers, but let's see if other people can do this too. How would you guys approach this differently? ERCP. Everybody agree with ERCP? CAT scan first. CAT scan first. Anybody disagree with that? Anybody would say do an MRCP first? MRCP first? Okay, so lots of different opinions. And how would you approach it?
Probably do an MRCP first, because she may have passed the stone spontaneous.
Oh, I like that. MRCP first because she may have spontaneous. Oh, I like that very much. Be cost effective, stay away from the invasive stuff. So that's appropriate. So I would think about MRCP. I would think about an ERCP under these circumstances. CAT, not so much, because again, the sensitivity of a CAT for what we're looking for, which is the biliary tree, is less than the sensitivity of the ultrasound. So I would look at things like either MRCP or ERCP under these circumstances, and that's the way that I would approach it. Endo, HIDA, the rest of that, I don't think would be particularly helpful.
Would you differentiate MRCP from ERCP, please?
Oh, MRCP from ERCP? We're going to have the audience do that. So the people who are telling us about MRCP, what's an MRCP? So it's an MRI detailing the biliary system. It's an MRI detailing the biliary system, non-invasive, non-complicated, easy to do in most medical centers at this point, and quite successful and quite specific for, not perfect, but quite specific, less specific than ERCP. But again, you have an older patient, a sick patient. You don't want to subject them necessarily to an ERCP first. You go for an MRCP, you see something definitively there, and you know what I'm talking about, that 94-year-old patient, and you've been with her for 45 years, and she's kind of teetering. She's got other medical problems. You're going to do that MRCP first just to make sure before you do have the gastroenterologist think about something else. So would we approach Myra differently if she had a normal common bile duct? No, you don't approach it differently because it's the criteria are either elevated liver function tests and or dilated common bile duct. Under those circumstances, with elevated liver function tests and fever, you would not have approached it differently. Incoming, those of us who are parents and grandparents and won't know what that means, all of the following are risk factors for gallstone disease, except, go for it. Okay, we're heading in the right direction. So atorvastatin use, exactly right, but clearly the teaching message is these other things, the obesity, pregnancy, rapid weight loss. We see that in the hospital all the time. ICU patients before they, while they're hospitalized for a week or so, before they're starting to get hyperal, rapid weight loss. So you have a patient with one medical problem, and then suddenly they end up with a second biliary problem, and that complicates things significantly under these circumstances. So rapid weight loss is part of this as well. Lisa, 60-year-old lady with lap chole 2 days ago for multiple gallstones, now has diffuse abdominal pain, fever to 103, tried to reach her surgeon who is out of town. I meant to say town. After telling her to go to the emergency room, you review the case in your mind, and what tests should be done in the emergency room? And what are we thinking about? Right side of the room. What kind of perforation? Biliary leak. Congratulations, biliary leak. And what tests should be done in the emergency room? Yeah, CT scan. You know, something along the lines of a CT scan, which is exactly the direction that we should be headed. And if somebody told me I want to do a HIDA scan, that would be another way of looking at it as well, because a HIDA scan can sometimes also show us leaks. How do I assess a patient who has been on atorvastatin and now has elevated liver function tests? This is stuff you guys see all the time. I used to get these consults 2 or 3 times a week. So now we know that it's not necessarily important to stop atorvastatin. And again, if the liver function tests are within a range, some people say 3 times, some people say 5 times, some people even say 10 times. But again, in my experience, most of these people have had a fatty liver. Uh-oh. What's new in hemochromatosis? And what's new in hemochromatosis? There's a couple of interesting things. I just want to point this out to you to just kind of keep you up to date, because there's a couple of learning points here that's all changed. So John is a 50-year-old male referred for elevated liver function tests. Feeling tired for years, thinks it's due to the fact that he works 2 jobs. Joint pains and diabetes, so that all goes along with hemochromatosis. And obviously the iron binding capacity, ferritin, all abnormal. Which test should we consider? Wow, you already know this. Great. So why should we consider genetics? Because it has an 85% probability of being correct. Congratulations. Because again, not everybody knows that in primary care, so this is the key. Remember, years gone by, we used to be biopsying a huge number of these people, you know, one after the other. So the answer here is the genetics testing, which we're going to talk about in a couple of moments. And this can avoid liver biopsy. The whole point here, and we have this sense about medicine these days, if we can avoid that risk, these invasive tests, that's where we want to be. That's where we want to be. And we are able to do that these days by, at least in the hemochromatosis arena, by doing the genetics. So for extra credit, and I've got this special award in my pocket, can anybody tell me what elastography is?
Shaking the liver under ultrasound to see whether or not there is hardening and fibrosis of the liver.
Okay, here you go. This is the gold medal for today. Wear it proudly. You are first place in the Olympics. Okay, so that's, I'm going to repeat this for everybody so you hear this. Elastography, and you're going to remember it by this story. Elastography, this is something, my friend, you may not even be aware of. elastography was developed in France. It was developed many years ago to check the firmness of cheese. So you're going to be thinking Dr. Buck, New York cheese, and elastography. Elastography is a machine that my friend was just telling you about that is available in tertiary medical centers, almost all the medical centers who have liver transplant capabilities, and many other facilities these days. It shakes up the liver to be able to tell you in a non-invasive way if there is fibrosis. So I'm repeating that. It tells you in a non-invasive way if there is fibrosis. Isn't that great? So they use it. Think about what I'm going to tell you now as a parenthesis for what we're talking about. So they use it as a standard of care now in hepatitis C, and we're going to talk about hepatitis C in a moment. Standard of care because not everybody with hepatitis C needs liver biopsies. And there is also a blood test that you can use called FibroSure, which is a blood algorithm and gives you pretty accurate information that's available in many laboratories these days. It's an algorithm of ALT, AST, many other components within the blood, which will also give you a fibrosis score in the liver. So isn't this great? I'm trying to cause fewer liver biopsies out there. Liver biopsies still have their role because, again, none of these tests are perfect. And again, following through is oftentimes important with a additional test, but there are other ways of looking at it. So let's talk and get back to the hemochromatosis genetics. So if we have a 282Y homozygous, they have hemochromatosis. If we have a heterozygote, as you see underneath, 282Y, 63D, well, it's probably going to be about a 60, 70%. They may or may not need liver biopsies. That's the kind of thing that's going to be a judgment call. But certainly if they have the 282Y homozygous, that's it. We don't need the liver biopsy at all. Let's continue. We're on to hepatitis C and wrapping this up today. Jack is a 26-year-old gentleman who used heroin once while in college. And routine exam 3 months ago, physical was normal. Liver function tests were elevated. 3 months later, normal. Then 1 month later, elevated. And what should we do? Hep C, looking for hepatitis C, clearly. Here's the message that I want to share with you. So everybody in this room is sure that when you have liver function tests that go up and liver function tests that go down and go up and down again, that can be part of that component of hepatitis C. It is not unusual to have that. In fact, it's very common to have that as part of the hepatitis C component. I can tell you of many consults over the years where the first liver function tests were elevated and the second one was normal, and a patient was told that they don't have anything to worry about. That's when you really start to get worried, when you're maybe misdiagnosing or avoiding that diagnosis of hepatitis C. So who should be tested for hepatitis C? What's that?
45 to 65.
45 to 65, and? Okay, drug. Tattoos, that's great. Yeah, you get extra credit for that one. Hemodialysis people, right? And there's I'm sorry?
In prison.
Prison, yeah, prison. It's not part of that standard, but I would say that probably would be reasonable. And then it's at-risk sexual population, gay population, promiscuous male gay population. We're going to talk about that. So here we go. We already have this. Go ahead. Answer. Perfect. High-risk sexual behavior, HIV, anyone born between 1945 and 1965. We know it's important to get tested, and breastfeeding is not a risk factor at all. So here are the tests. They can be any kind of hepatitis C antibody. than hepatitis C RNA testing. What does a positive hepatitis C antibody test mean when hepatitis C RNA is negligible? I heard that from way back. Spontaneous cure. So we have to do both together because, again, the PCR or whatever antibody test we do can still be positive. We have to have the RNA because, again, about 20% of these people will clear the hepatitis C virus. Lucky few. But it happens, and we don't need to move any further with them.
It could have been treated too and cured.
They could have been treated and cured. That's exactly right. That's exactly right. But the teaching point here was that if you have a patient coming who's never seen a doctor before and they have this combination, they have resolved the virus on their own. 20%. 20%. As opposed to hepatitis B, how many will clear the virus on hepatitis B as an added? Yeah, it's about 80 to 95, yeah. So it's a direct opposite of hepatitis B. It's a whole different thing. So hepatitis C sticks, hepatitis B, lots of them clear out of the system. So sources of infection for people with hepatitis C, this is stuff we already know. What's the risk of hepatitis C transmission by sexually active patient, long-standing monogamous heterosexual couple? There we go. Wonderful. Yes?
About 20 years ago, I was taught that in the United States that's true, but that in Japan it's kind of the reciprocal, and that something like 40% of it's sexually transmitted. Since then, I've never heard that again.
Yeah, I've not heard about that again. In fact, the CDC is so specific, they said no additional precautions are necessary in this country. That's how,
You haven't heard the thing about?
I've not heard anything about Japan. No. So here's some bonus questions. Statins okay for use in hepatitis C? That's questions you're going to get all the time. Yeah. When can it be problematic? When they're really sick, when they're, cirrhotic, end-stage cirrhotic kind of things, and you wouldn't have to worry about, any sort of medicines along those lines anyway, right? So that's when it can be really problematic because the whole key here is we shouldn't be taking away medicines from these people who have a long lifespan ahead of them, and that's the message. Any problem with acetaminophen? No, same thing. So if it's end stage, and I get these questions all the time, I don't want to give, and it's usually along the lines of this. I don't want to give my patient who has, it usually ends up with varices. I don't want to give my patient Tylenol. I'm going to give them aspirin. It's a disaster. It's going to end up with a disaster. The key is, and the answer that you guys already know, acetaminophen is okay as long as it's not cirrhosis going into end-stage cirrhosis being varices, hepatic encephalopathy, and ascites. So those are the criteria. Should cirrhotic patients cured of hepatitis C still be evaluated periodically for hepatoma? Absolutely. They're going to end up in your practices because gastroenterologists are going to be doing 15 or 20 procedures a day. Patients have been quote unquote cured. They may not be followed up with the ultrasound. You guys are going to be ending up with a catcher's mitt of these kinds of patients. You need to make sure that they have their screening, which includes ultrasound. Ultrasound, the standard of care is every 6 months. Nobody's basically doing that. We should be doing that, but they should be getting ultrasound on a regular basis. If they don't have cirrhosis, you don't have to worry about it. Cirrhosis, you do. What percentage of hepatitis C patients develop cirrhosis in 20 years? Oh, I already heard the answer. 15%. Let's move on from there. Okay, let's wrap this up today. Current therapies. I don't want to talk specifically about the current therapies. They're all over the place. They're algorithms. There are all kinds of complicated ways of approaching it. And basically, as many people in my primary care audience have always told me, it's not so much the medicines, it's what's the HMOs and the government will allow our patients to get. Here's the good news. There is some good news among all of these things. Do we have anybody who has gone or comes from Egypt or India? Egypt or India? Okay. In Egypt and in India, the price of sofosbuvir is $6 to $9. $6 to $9. That is absolutely incredible. We know that the price of current hepatitis C treatment in this country varies. It's going to be $1,500. It varies from about $80,000 to $90,000 to $1,500. Luckily, there are a lot of progressive thinking people and HMOs out there that are going to allow patients to receive the therapy. But one of the cautions that I have for you, when you all are doing the appropriate screening for the patients, we talked about that before, 1945 to 1965, I want you to be aware, and before you do that screening, to make sure that their HMO, if it is positive, will pay for the positive results. The worst things that you can end up with, my friends, is to have a patient with a positive result and the HMO won't pay for it. So think about that. I still want you to do the screening, but I want you to start to think about this in advance and knowing who will pay for what. And then you can counsel your patients appropriately because you don't want to be stuck in that squeeze in between. All of the following are complications of hepatitis C except, cardiomyopathy, people. You are the right ones. Keep on piling it up. All of these others can be complications. Thyroiditis, renal disease, diabetes can all be part of that process. So cardiomyopathy, I'm glad you piled in there. Any indications for interferon use in hepatitis C in 2016? Probably not. Probably not. There'd be situations in certain of the states where nobody's paying for the appropriate medicines. We really don't want to go back there because of all of the complications of ribavirin and interferon if we can avoid it. So who assesses cirrhosis progression to liver cancer in your practice? That's what we re-emphasized before. I don't want them to fall through the cracks. Even though gastroenterologists may not have seen them in years gone by, you're going to be seeing them a lot more than the gastroenterologist in follow-up. Make sure. So how do we assess this? How we assess this is ultrasounds. Ultrasounds, does anybody want to say that they use alpha-fetoprotein? Not anymore. That's exactly right. Because sensitivity and specificity, they're false positives. It's not that we can't use it, but if you get, the trouble is if you get a 300 or 400 range, then you're stuck. You're trying to figure out. If you get a 2,000 range, you got it. There's a hepatoma there. But if you have a 300 or 400 range, which happens very often, that's why a lot of the societies were saying stay away from the alpha-fetoprotein, stick with the ultrasound.